I'm Steve Monteith. I'm a neurosurgeon here at Swedish. Firstly, I'd like to thank everyone for coming, and to Ryder and Johnny for giving me the opportunity to speak. It's amazing. Bill Rebus used to come to UVA every year to give us a week of talks, and every year you learn something new, and it's a great privilege to catch up with Bill again and see that he still has the same passion for anatomy. I'm going to talk about the potential for MRI-guided focused ultrasound in the brain. Disclosures. We're just going to go through some background and history. Dr. Cassell, who's a mentor of mine at the University of Virginia, says he came up with his eureka moment when he thought of focused ultrasound and then realized that he wasn't exactly the first person to come up with this idea, the idea being concentrated beams of energy focusing onto a deep spot deep within the brain, similarly to burning a ray of sunshine into a leaf. This idea has been around for a long time, and I'll get to that in a minute. It's the combination of focused ultrasound energy as well as combining that with the eloquent imaging of MRI. Ultrasound's been around a long time. Back in the 1800s, this piezoelectric effect of using ultrasound energy was discovered. And now, moving along up until more recent times, it's been used in medicine, not just for looking at babies. The Fry brothers in the 40s came up with this thing they called the Fry's monster, the idea being that you could use focused beams of ultrasound to create high energy at a focal point deep within the brain. And of course, Lexell in the 50s tried to do this through the skull, but couldn't get through the skull, and so had to make a craniectomy window. Since then, of course, changed over to the Gamma knife in 1967 because he was unable to focus the intersecting beams of ultrasound through the skull. He was already sort of ahead of his time. The technology hadn't caught up. The idea of hypothermia for the treatment of brain tumors has been around a long time as well. The same idea, if you could use ultrasound to cook the tumors in the brain. So we've come full circle. The technology is now caught up. We have the ability to get through the skull. And we have the ability to image the brain with exquisite detail with MRI. So we can use these focused beams of ultrasound that focus deep within the brain to a focal spot with sub-millimeter accuracy. And the idea being that these 1,000 beams that go in through the skull, each one of them doesn't do too much, but when they meet in the middle, they do a lot. We've been able to overcome these issues of skull correction. The skull is very irregular, as we all know from operating on people. And this defocusing effect has now been obviated with CT scanning and a complex computer algorithm. The effects at the focal point vary depending on what parameters we turn the ultrasound to, from simple thermal ablation to temporarily opening the blood-brain barrier, dissolving clots, radiation sensitization, delivering drugs, so on and so forth. The amount of energy that's required to kill tissue, we know that if we get above 57 degrees for a split second, that tissue's dead. It's like cooking an egg. Or if we kind of slowly cook something for 240 minutes at 43 degrees, that's not very practical for clinical treatments, and so we tend to aim for sort of these high temperatures in the 50s. The treatment planning is similar for those that have done the Gamma knife. We outline areas that need to be treated, areas that need to be avoided. Then the computer fills that area with treatment sonications, or sort of each shot, so to speak. And we can monitor the treatment in real time with MR thermometry. So the MRI can tell us which areas of the brain are heating up. And then we can confirm by taking an MRI scan what exactly we've done. And this is just a picture of the planning software that we've been using here at Swedish. The thermometry is extremely accurate. Every 3.7 seconds, the MR can tell us exactly how hot pieces of the brain are getting when we're delivering this energy. And so for the functional applications, which we'll talk about in a minute, that's really important. We know exactly how hot things are getting, so we know whether we've created a permanent lesion. It has very sharp margins. This is just showing how sharp the margins are. You can see with the arrows, there's a very steep cutoff. It's actually sharper than a Gamma knife, and it's similar to RF ablation. So the idea or these advantages are fairly obvious. You get an immediate effect versus radiation. There's no cumulative dose issues that you get with radiation, and you can keep going back as many times as you want. So some of these applications, which we'll talk about, that could be very powerful. This is just a kind of a grab bag of all the potential brain indications. Some of these have already come to fruition, and we'll show you some of those. And some are kind of in preclinical stages, and some are even further back. It's not going to treat everything. It's not going to treat scoliosis. We'll leave that to Dr. Askewian and colleagues. This picture here is kind of interesting. This traumatic injury, this guy shot 23 intracranial nails into his own head to treat his persecutory delusions. Interestingly, he survived, and he had far less persecutory delusions after that was done. So current state, back in 2010, focused ultrasound was used to treat chronic neuropathic pain in Zurich with thalamotomy treatments. This is a picture of a device similar to what they used. And then we can see over time the change in the lesions on the MR. You can see in the thalamus where the thalamotomy is. Dr. Elias was the pioneer of the study at UVA, which I was lucky to be a part of as a resident, using for the treatment of essential tremor. And that pilot study of 15 patients was published in the New England Journal. And what it did show, here's an example of the thalamotomy you can see here. And it changes over time. There's a bit more swelling at day 7, and then the lesion goes down as we follow out to 30 days. And just with the flare, again, you can see that there's an increase in flare signal at day 7, there's an increase in swelling, and then it goes down. Intraoperatively, we have the same protocol here at Swedish that Dr. Gwyn's been heading up with the essential tremor trial. This is an example of the pre-testing and then afterwards the testing that we do for essential tremor. You can see the lines, the spirals and lines are much straighter, and the tremor has improved significantly. And that is correlated with these outcomes at 1 year. You can see these are each of the patients for that pilot study, and 1 year out, the quality of life scores were significantly better. And so when you go from a quality of life score from 35 to 10, it's the difference between being able to dress yourself and feed yourself and that sort of thing. Real basic stuff that we take for granted, but it's a huge quality of life changer. So this is an example. This is the first patient that was treated. This is a simulated eating task where these beans are taken from a little cup there and attempted to be moved into the other side. You can imagine it's impossible to eat like that in a restaurant. And this is the post-procedure. So you can see there's a significant improvement there, and that's really a life-changing improvement. And we've had similar experience here at Swedish. We can't talk about the results because it's part of an FDA trial, but we've had, I think, very positive outcomes overall. So where are we at in terms of what are we doing at Swedish? Dr. Gwyn's been leading the charge on the essential tremor and tremor-dominant Parkinson's disease. We joined UVA in the tremor-dominant Parkinson's disease trial. We're also treating brain tumors with metastatic tumors. Myself and Dr. Cobbs treated the first patient with a metastatic brain tumor a couple of months ago. Gliomas have been treated in Zurich. They've treated a couple of patients. It's also been used in Europe for neuropathic pain. Epilepsy we'll talk about shortly, as well as intracerebral hemorrhage. OCD is getting a lot of press in South Korea. Dr. Chang has treated several patients treating the anterior limb of the internal capsule. With brain tumors, originally they did it with a craniectomy for a proof of concept, and then Dr. Yolas treated glioblastoma as a proof of concept, and then we're doing the metastatic brain tumor trial here. We have found it's a little difficult to recruit patients. We can only treat patients with 3 or less lesions, and they do have to be in the center part of the brain, just due to the limitations we have with the mechanical steering of the device at the moment. And the treatment time is a little slower than we'd like. due to the nature of the testing that we have to do in the setting of a clinical trial. During the procedure, we have to constantly test the patient to make sure that they're safe. There's research for brain tumors as well, 5-ALA, targeted drug delivery, this idea that we can temporarily open the blood-brain barrier and deliver chemicals to the brain in a very focal spot by using focused ultrasound. So we can have a drug that's circulating through the body, doesn't do anything, and then we zap it, and these little microbubbles explode and deliver a payload at the site. So we can package these medicines into these nanoparticles or microbubbles, and then they float around through the body like that, and then we hit them with focused ultrasound just in the brain, and they release, and the rest of the body doesn't absorb any of that potent chemical. So this is of particular interest for the so-called impossible lesion, these meningiomas in the cavernous sinus and so forth that are just notoriously difficult to treat, might have failed gamma knife or something like that. This is ideally where targeted drug delivery could have a huge role in the future. The amount of energy needed to treat with targeted drug delivery is much, much less. We don't have to thermally ablate any tissue. So some sort of thinking outside the box ideas that we had with focused ultrasound, looking at the treatment envelope. This is the area of the brain that we can currently treat with different devices. The red device is the current device we're using clinically, and the green one is an experimental device. With the findings in the ROSE trial with radiosurgery for epilepsy, we were interested in using focused ultrasound for the treatment of mesial temporal sclerosis and other potential targets of epilepsy. I'll talk a little bit more about mesial temporal sclerosis shortly. Other sort of more easy targets would be centrally located lesions like hypothalamic hamartomas or tubular sclerosis. They're kind of right in the hitting zone of the focused ultrasound. So back in 2010, we looked at treating the temporal lobe with focused ultrasound, and then we've gone on and done some more preclinical work on that. You guys all know what epilepsy is. This is the area that we have to treat when we do surgical excision. And Dr. Rebus has been going through all of these anatomical structures in great detail, so I won't quiz you on those. But that's the area that we would typically remove depending on whether we did an anterior temporal lobectomy, anterior medial temporal lobectomy, or a selective amygdalohypocampectomy. And so the idea is that we use the focused ultrasound. This is just another picture of the device. This is the helmet with the MRI. And so we did some testing to see if we could kind of get through this volume and get an appropriate thermal rise or lesional temperature in these areas. And what we were able to do was kind of raster our way through and treat the temporal lobe as if we had been doing a surgery. And we did get lesional temperatures of 60 degrees in this area, which would be typical of what we would get in clinical setting for thalamotomies. We measured the temperature of areas of the skull base because we were concerned that the skull base may heat up from some other preclinical work we did. And we need to be careful of that. You can see one of these curves here heats up 12 degrees when we got a lesional temperature in the brain. The petrous apex did heat up, and so that's something that we need to think about and change our tactics of how we target the lesion, basically by turning off more of the beams that come from the top because they have a shadow effect that goes through to the skull base. So this is in the preclinical phases. There is interest from us and another group in the US to go ahead and treat patients. We've submitted an article to a well-known journal, and that should be coming out reasonably soon, I hope. CSF diversion is another idea. Bust a hole in these membranes and join the CSF spaces. We did this with septum pellucidotomies and also with third ventriculostomy, the idea being that we can cavitate or blow a hole in the bottom of the third ventricle with one shot. And then, of course, with the MRI and cine flow studies and so forth, you could make sure that you've re-established CSF flow. It's a very eloquent, non-invasive way of doing it. Trigeminal neuralgia, we all know what causes trigeminal neuralgia. The rationale is similar to the non-invasive methods of gamma knife. You don't need to have open surgery. and obviously it's no radiation. And so we did some preclinical work on this, which proved that it was feasible to get a lesional temperature in the root entry zone and the trigeminal nerve in the cisternal segment without heating up adjacent tissues. Psychiatric disease, we were interested in that too. The anterior cingulate gyrus is a target that's been used for depression and OCD in the past, and it's been used as a target with stereotactic radiosurgery. Dr. Chang in South Korea has gone for the anterior limb of internal capsule with good results. We had a proof of concept study showing that we could get the cingulate gyrus. The other interesting thing that we've been looking at is the treatment of intracerebral hemorrhage. We know that ultrasound can help the dissolution of TPA in the treatment of intracerebral hemorrhage. My colleague David Newell looked at that here at Swedish. And we know with ultrasound we can accurately lyse blood clots through a skull, and this is just a preclinical thing that we did. Here we can lyse the blood clot. The pre and post, the increased T2 signal is indicative of liquefaction of the intracerebral hemorrhage, as you can see here. And then we were able to aspirate it with just a stylet through a tiny little small skin incision in the MR and aspirate these liquefied clots. And there's a clinical trial which is in the planning stages in Canada to use that technique. So we're interested also for ischemic stroke. If we can bust clots in the brain for intracerebral hemorrhage, then it stands to reason that we can bust up clots inside blood vessels. This is an example of a patient that came in with a left Mca Syndrome. You can see here on the left there's no middle cerebral artery, and then on the right there's still no middle cerebral artery on the lateral view. This is typically what we're doing now. Many trials have shown the effectiveness of these stent retrievers. This is what I do. I'm an endovascular neurosurgeon. And so we can remove these blood clots with these stents that pull the clots out and re-establish blood flow. You can see on the right panel, the MCA is now wide open. So that's the competition. We can do that pretty fast. Some of the fellows here have got really fast at doing that. But we thought, well, let's see if we can do it with focused ultrasound. So we took a cadaver to the lab and gave it a stroke and put some clot in the middle cerebral. You can see the filling defect there. And then with the ultrasound device, we essentially zapped the middle cerebral artery with different parameters of the ultrasounds. We can mechanically perturbate the clot rather than cooking it. We just mechanically disrupt it. And we can show with a time of flight MRI of this cadaveric specimen, we developed a way of basically giving a cadaver a pulse. And we can see that we can open up these blood vessels. So there's interest in using focused ultrasound for the treatment of ischemic stroke. So if you're good with a hammer, you think everything's a nail. Of course, it's not going to work for everything, but this is a very exciting technology that we're at the forefront of here at Swedish. There's 5 devices in the US and another half a dozen around the world. And we're sort of really looking to each of these new applications and hoping that we can make our patients better with these more minimally invasive techniques. Obviously, you don't want to get in there with your 23 intracranial nails. It's going to take some judicious application of the new device. There's always a wave of enthusiasm to treat everything you can under the sun. That happened with the Gamma knife. It happens kind of with everything in neurosurgery and in medicine. So in conclusion, there's an unmet need for many neurological diseases, and focused ultrasound is really emerging as a treatment modality for many of these intracranial pathologies, and it's an exciting time with a huge opportunity for research, and that's something that we're cultivating here at Swedish. Just like to acknowledge a couple of people, Ryder obviously in the room, who's really been driving our focused ultrasound program, as well as the people that you see there. 1 minute to spare. Any questions? Thanks.
Very cool stuff. Any questions? How many people have already heard of focused ultrasound? Have you guys all heard about this as a tool? Everybody here. One of the most impressive things, I think, just looking at this is from the Dr. Elias, the pilot study, you look at the time frame on the FLAIR images for the VIM treatment, you can see there's just a very small change in the flare signal at 7 days after. If you look at anybody that, if you get an MRI and somebody has a DBS electrode placed, there's like flare signal everywhere just from placing the DBS electrode. So the amount of kind of fall off between the necrotic tissue and the ability to not perturb anything else around it, I think is greater in this technology than anything I've seen so far. So we're really excited to be able to use this as a tool.
I'll be fortunate to see how your treatment here with the neuropathy. You think 10 years from now is going to be DBS?
That's a good question. It's presumably still a ablative therapy. So if we do create side effects, they're probably not likely to get better on their own after a recovery period. So there is an irreversibility to it that's presumably not there with DBS. There are some potentially permanent things that can happen with DBS, but I think that there will always be, in the foreseeable future, there'll be a role for having reversible therapy. But I think that the proof is in the pudding. You know, the patients are going to choose with their feet. And if we can get them essentially the same level of tremor control, have a very decent profile of side effects, I can't imagine virtually anybody choosing EDS over this. So it's really going to be about how well you do with side effects and getting good tremor control. Yeah.
You still can make bilateral lesions.
You can. As he showed for pain, they're doing it in Switzerland, I think. For
some people have been doing bilateral lesions, but you know, for lesional procedures, we've kind of shied away from that.
Yeah. The protocol for essential tremor and Parkinson's, which are the only two protocols other than the tumor here, is none of them allow bilateral treatment. And I'm sure that at some point, you know, if this is FDA approved, people are going to start doing bilateral treatments. There's already, you know, gamma knife is used bilaterally to treat VIM. I would say I would, but there are people doing it. And so again, you know, if we can show that there's not a lot of cognitive or other problems resulting from it, yeah, I think it's probably looking at that. Great. Thanks a lot.
Oh, perfect timing.
So yeah, why don't we go ahead and change and head over to the